Today's talk's a bit of a strange one. It's on dizziness and loss of consciousness, which isn't in the title, but that's what I wanted to do it on, because they're obviously not the same symptom at all, but they are related. And I wanted to do a talk on it because it's actually a very common thing you see on the wards. You're often called to see patients because they're feeling a bit dizzy, or their consciousness levels dropped. And it's a really important symptom to be able to understand and manage. Okay. So as always, we will start. I imagine some of you have been to previous talks, but if not, I will just run through quickly. I'm Jamie. I'm a F2 doctor at Guy's and Tommy's, and I've given a few talks now. So the idea of this is it's an A to E systematic approach, but with a focus on a particular symptom for each talk. Okay. So the A to E approach is systematic. It's used by lots of different healthcare professionals of all levels of seniority, and it's really useful in an emergency scenario because if you're panicking or if you're a bit concerned, then it just gives you a framework to work through the most important things. Okay. A couple more have joined now. Excellent. As always, be systematic. ABCDE, that's the order that things will kill you the quickest or cause serious damage the quickest. Escalate early, particularly as a junior doctor, particularly as an F1. It's really important that, and communicate well with everyone on the wards. So airway, as we've discussed before, look at it. Is it patent? Can you hear breathing at all? If you can, does it sound like there's an obstruction? And if there is, then basically call the anaesthetist there and then, because that is very problematic and the patient is very, very unwell, particularly if they can't maintain their own airway. And then if the airway is not patent, if it's partially obstructed or obstructed, you can use maneuvers. So head tilt, chin lift, or jaw thrust, or you can use airway adjuncts like this. So one is a Goodell, which just goes in the mouth. Two is a nasopharyngeal, which goes in the nose like a nasogastric tube, just goes down to the back of the throat, keeps the airway open. And three is an eye gel or an LMA, and that's a slightly more definitive airway. Okay, and then the one the anaesthetist use tends to be endotracheal tubes, which are more permanent. Okay. Breathing next. Are they breathing at all? If not, check for a pulse. You might have a cardiac arrest situation. If they are breathing, are they very tachypneic? Is there an increased work of breathing? Do they look a bit blue? What are their SATs doing? And then examining them. Is the chest clear? Are there any crackles? Is there a silent chest on one side? You can percuss to feel for whether the sound is hyper-resonant, which would indicate a pneumothorax, or hypo-resonant, which would indicate some fluid in the lungs, such as an effusion or a hemothorax. Get a gas if their SATs have dropped, and importantly, treat them with oxygen, because even if they are in type 2 failure, or you're worried about type 2 failure because they've got COPD, hypoxia kills someone quicker than hypercapnia. Okay. So initially treat with oxygen before you get more senior help. Circulation, look at their obs. Are they tachycardic with a low blood pressure, which would indicate shock? Are they bradycardic, which is slightly more unusual? Or have they got a really high blood pressure that you need to control, particularly if they're symptomatic with that? Look at the patient themselves. Do they look really pale? Do they look really sweaty and clammy, as if they're shut down? And then the examination, have a feel of their pulse, look at their fluid status, their cap refill time, look for their JVP and any fluid on them, and have a good listen to their heart. Try to get an ECG from the nurse, but again, it's not an urgent thing. ECGs do take about 10 minutes to get. So you can ask a nurse to do one while you carry on with your assessment. And then if they are in shock, get a cannula in, get a fluid challenge, a fluid bolus, and see if they respond. And then we can think about getting more maintenance fluids. If they've lost blood or they're hosing out blood, put out a major hemorrhage protocol, and you can get some blood there, some O negative blood, which you can put in you can put in as quickly as you need. Next up, sorry about that. D is disability, which is probably the most important one for what we're discussing today, I would say. So they go in order of importance, but this is probably the most relevant with dizziness and consciousness. So as you see there, you've got GCS or AVPU. AVPU is very much accepted. That's fine. So are they alert, responsive to voice, pain, or are they unresponsive? GCS is just a bit more detailed, and I've written it up there for you. So you can see how responsive they are to eye opening, to verbal responses, and also are they obeying motor commands, and what's their best motor response. Okay, I won't go through that all, but you can feel free to take a picture, but it's very easy to Google the GCS score. Check their BMs. Okay, it's a very common cause of people being a bit drowsy, a bit confused, a bit giddy, dizzy, and even unconscious. So that's normally hypoglycemia, but can also occur with hyperglycemia secondary to dehydration. Check the pupils. Have they had an intracranial event that you need to be very concerned about? So that's one to definitely not miss in a patient that has a reduced GCS level or is feeling a bit under the weather. And then check the temperature, see if they're febrile. Exposure, so cater this to what you think. So if you've got differentials in your head, you can use the exposure part to try and work out and get a bit more detail about what's going on. If you have no idea what's going on, that's absolutely fine. Just stick to quite a systematic approach, do an abdominal exam, look at their lines, see if there's any rashes or wounds, and check the neurovascular status as well. Okay. So after A to E, reassess, look at all the notes, drug charts, scans, bloods, all of that sort of stuff. What's their escalation status? And then consider doing further investigations that you need, be that imaging, be that ECGs, be that bloods, gases, all of that. Okay. So this is what we're talking about today. This is dizziness and loss of consciousness. So as I said, very much not the same symptom at all, but they are sort of related, which is why I put them together. Okay, so dizziness, there's a number of causes of dizziness, and there's a number of causes of loss of consciousness, but it's just good to have a wide differential list in your head. So I haven't listed differentials as such, but I've listed systems and things you need to think about when someone presents with dizziness or reduced consciousness. Okay, so the first is cardiovascular as a cause, the main one being actually hypovolemia. So I've put that in cardiovascular, but anything can cause that. Could be septic, it could be cardiogenic shock, it could be neurogenic shock, distributive shock. Okay, but I've put that in the cardiovascular. So low circulating volume can lead to dizziness and can lead to reduced consciousness. Okay, another cause of loss of consciousness would be something like aortic stenosis, so reduced output from the heart itself, commonly from a murmur such as aortic stenosis, but can also be due to arrhythmias and effusions, and so that all goes under the cardiovascular bracket. Neurological, so that can be infectious, such as meningitis. It could be an intracranial event, such as a massive hemorrhage. It could be a posterior stroke, so a big basilar stroke can cause unconsciousness, but more minor strokes can often cause sort of dizziness and feeling a bit giddy. And then auditory I've put in as a very common cause of dizziness, but in particular vertigo, which tends to be more positional. And so your causes of that are benign paroxysmal positional vertigo, so that's BPPV, but also ear infections such as labyrinthitis can cause it, and Meniere's as well. And then medicines is a really important one, okay, to look at. So I'll get you guys to be interactive when we're going through the cases, but particular medicines to be aware of are antihypertensives, as well as diabetes medications that can lower blood sugar levels, and also sedatives and tranquilizers are common causes of dizziness and confusion and reduced consciousness. Okay, and then toxins as well. So drugs, opiates, heroin, alcohol, particularly if they're coming into A&E. All right, less likely on the ward, but it does happen. Patients do still manage to get things on the ward. Okay. And then endocrine causes I just put in there. So that's low BMs, typically in a diabetic patient who's taken too much of their medication, or if they're taking the normal amount of the medication but they're not eating as much, or they're not a diabetic patient but they are have significantly reduced oral intake, they can become hypoglycemic. Okay. Any questions, do just pop them in the chat, guys. I will answer them as we go along. So, first case, you are called to see a 75-year-old man on the orthopedic ward who is complaining of feeling a bit dizzy and a bit giddy. He's meant to have a total hip replacement today. It's about 10 o'clock. You're just covering the ward bleep. Oh no, let's say it's about 7 o'clock. The day hasn't started yet. Ward runs at 8. And you're finishing your night shift. So as with any case that we do, A to E systematic approach. As you can see there, the past medical history, the nurse is able to tell you that on the phone, which is very useful. So it looks like they're a bit of a vascular path, basically. And they've got some arthritis, which is affecting their, which is probably why they're having a hip replacement. All right. So just working through the A to E. Airway is patent and central, so that's not a concern. Breathing, SATs appear fine, their respirate's fine, and they've got normal breath sounds. They don't appear breathless. Their circulation, they're hemodynamically stable, cat refill's good, they are warm, well perfused, heart sounds 1 and 2. So ABC we're pretty comfortable with. So I've deliberately left D&E blank. What do we think, guys? Just pop in the chat and make sure you're writing to everyone, not just me. What do we think we need to look at for their disability for this gentleman? What's going through our minds that might be causing this guy to be dizzy? Okay, low BMs, very good. Yeah. Anything else? Anything else in D that we need to check? You're absolutely right saying low BMs. Yeah, very good. Okay, so get the GCS. His is 15. He's not confused, but he's just feeling a bit lightheaded. Pupils are fine, both equal and reactive to light, and he's afebrile. So you do a blood glucose on him, and his glucose is 2.2. Okay, and we know from his history that he's got type 2 diabetes mellitus. So what do we do next? Before I move on to the next slide, what do we need to do if he's got a low glucose? What do we need to think about? No worries if not. So yeah, absolutely, Amy. So treating the glucose is the most important thing. You're quite right. So if it was 2.2, I think I said I'd probably replace it intravenously. And you can give just what is it, probably 50 mils of 50% dextrose IV just to get the BMs up. If it was a bit higher, if it was sort of low to mid 3s, you could give glucogel, sort of just rub it into the gums, or even consider giving some orange juice. and a Kit Kat, something like that. Good. And if it's really low and it's not responding to glucose, you can think about giving glucagon. Okay, but that's a bit more niche. So other than replacing it, which you will do as part of your ATE, fantastic. The other thing you need to think about in a diabetic is their med chart. Okay, so having a look at what medications they're on. Now, what's probably happened if this guy's going to have a hip replacement is he's nil by mouth, but he's probably been given his anti-hypoglycemics. So it's just being careful about what to give him, and maybe if he's going to theatre, chat to the anaesthetist about putting him on a sliding scale, because you don't want it to delay his operation, but you want to be as safe as you can. Okay, and that's a very reasonable thing to do. Okay, and then also if they're fine, he's stable as he was, take a good history, find out a bit more about the dizziness, just rule out other causes. So has he got any chest pain, any palpitations, any shortness of breath? Has he had any seizures? Has he lost consciousness or fallen? Okay, so all very important things to ask about. All right, but chances are you'll give him some glucose and he'll feel right as rain. All right. Any questions? Again, pop them in the chat. So, case number 2, you are bleeped by a nurse as a patient has fallen out of bed on the ward, fallen whilst getting out of bed and is now unconscious. Okay. Concerned, not concerned. How quickly are we getting to this patient? Anybody? Don't be afraid, guys. I don't, honestly, you can write what you want. Yeah. Okay. A couple concerned, one not super concerned, but still concerned. I like that. It's always that. It's, you know, it's you think about it as a binary question, but it's not at all. It's all at the level, isn't it? I'd say I'm pretty concerned if I had to grade it. And what I'm concerned about is they're fallen and they're unconscious. Okay. And try and get a bit more information on the phone. Because if they stood up and then they felt dizzy and then they fell, that's less worrying than they've fallen because they're unconscious. Okay. I hope that makes sense to everyone. So you go and you assess them. Airway's fine, breathing's fine. Okay. So immediately we're a bit more relaxed. But circulation, they're not tachycardic, but their blood pressure is 90/53. Okay. So they are hypotensive. Now, the easy thing to think with this patient is when you look at them, and I've seen a few, you think, oh, particularly if they're unconscious or if they've got a reduced GCS, it's easy to go away from the A to E approach and go straight to sort of working out what their GCS is and how responsive they are. Okay. And that's good. If you do it quickly, that's fine. But remember that it's ABC for a reason. Okay. So those are the things that are important. So we now know that this is a hypotensive patient, but other than that, they are fairly stable. Okay. Their breathing's fine and they're not tachycardic. Okay. So then moving on to D, they are responsive to voice when you get there. Okay. And that's a very reassuring sign because the nurse said that they're unconscious and they weren't responsive to anything, which indicates a GCS of 3. All right. But now they're responsive to voice. So their GCS is going to be higher, at least above 10. So we're not worried about the airway. BM's fine, afebrile, pupils are fine. Okay. So what do we think might have gone on here? If they got slightly low blood pressure with a recovering consciousness. Yes. Fantastic, everybody. So it sounds like that. And what would you ask? You might not ask, well, it's very good. Yeah, ask the patient, but also ask the nurse. What sort of things are we wondering? Yeah, absolutely. Pre-syncope. Okay, so syncope is collapse. So symptoms of postural hypertension. If anyone's fainted, that's a vasovagal. So they're similar in their symptomatology. And typically you get a head rush, you see SARS, and your vision goes, and then you black out. Okay. And what's really useful to ask the nurse is if she did a blood pressure there and then, because quite often you'll find that the blood pressure will have been sort of 60 systolic, okay, and it's now 90, okay, it's recovering. So that's quite a good thing to have in the back of your mind. So this, you've gone from having an unconscious patient to a now increasing conscious patient with a BP that is low but probably improving, okay. So I would, if they've got a cannula, I'd probably give them a bolus. If they don't, I'd probably recheck their BP in a couple of minutes and see if it's continuing to respond. Put their legs up to get some blood through to their head, because it might be that they don't need any fluid, particularly if they're responding well, okay. But the thing that you need to do that's written under E is a falls assessment, okay. That's really important. And it's important, obviously, first of all, for patient safety reasons, okay, because you need to see if they've injured themselves in falling. But it's also important from a medical legal aspect that you document the relevant things, okay. So my falls assessment, I do a bit of a history, find out what I think is the causes, rule out concerning things such as concerning features like chest pain, shortness of breath, palpitations, seizures, all of that. You document your ATE, and then I tend to just do a quick systems review for falls patients. So feel every joint, particularly hips, pelvis, elbows, shoulders. Feel the head, any bleeding, any cuts, wounds, any bogginess, any tenderness on the head. And then it's important to look at their drug chart, see if they're on any blood thinners, okay? So let's say this patient was just on 5,000 units of dalteparin every day as VTE prophylaxis, okay? But it was an unwitnessed fall, and they think they might have just slightly hit their head on the side of the bed, okay? What do people think? Do we think this person needs a scan of their head? Yeah. Good. Now, there is an argument, okay, to say that they don't, and that they just need some neuro observations for the next 24 hours. But I find it's always just best to be safe, okay? Even if it's in the middle of the night, it's best to say, if you think they've hit their head and they're on blood thinners, even if it's VTE prophylaxis, if they have had a subdural or a well, it mainly be a subdural, particularly in an elderly patient, and 24 hours later they suddenly deteriorate and you haven't scanned them, then you really don't have a leg to stand on, okay? So I always just say CT scan, this is the reason why, speak to the radiologist. Normally for head scans, they'll be fine to do them, okay? They're quite easy to get vetted. And then in this case, I think it's very appropriate. Anything else? And then think about what we can do to prevent further falls. Why did they fall? Why has their blood pressure dropped? So hold any antihypertensives that they're on, encourage oral fluids, and you can consider giving some IV fluids if you think it's appropriate. Inform the nursing staff. Do they need to be one-to-one? Do they need to be closely monitored if they're at risk of falls? So all of this is important things to consider, okay? And then any further investigations, I was getting at a CT head, okay? If they do have hip pain, get an X-ray of the hips and the pelvis, both hips, full pelvis, orthogonal views, so front on and lateral, just so you don't miss a fracture. And you can look at them, and if you're not sure, speak to a senior or bleep the ortho reg and just say that I'd appreciate it. And often they're not even sure, and will sometimes get a CT of the hip themselves, okay? So third one, I've got 4 in total today, guys. So, oh God, sorry. Oh, I've probably given it away with that one. Apologies. Hopefully not all of you saw that picture. So you get bleeped about a 77-year-old woman on the medical ward who is unconscious. Okay, as with the last one, there's no fall. This one is just unconscious, and that to me is quite a concerning sign. Over the phone, I would probably ask, are they breathing? Can you get obs on them? Have they got a pulse? That sort of thing. And the nurse, they should say, if it is appropriate, they should say, yes, they do. Yeah, they got a pulse. They are breathing. They're just not responsive. And that's fine. You're in a little bit less of a rush there, but you still need to get there pretty prompto. Obviously, if they're not breathing or they don't have a pulse, you need to do some running and put an arrest call out. Okay. So you get there, as with before, A and B are fine, nothing concerning at all. C, so they're hemodynamically stable. They've got, they're not tachycardic. They're warm, well perfused. Cat reflex time is 2 seconds, but they are pretty hypertensive. All right, 190 over 104, which in an unconscious patient, I would be pretty worried about, to be honest. But, you know, at C, there's not a lot more you're going to do there. Check their fluid status, check the cat refill. Are they really overloaded? But you might not sure you treat it at that point. You need to get a bit more information because we're not really going off much there. So then on to D. So their BM's fine, they're afebrile, but their GCS is 3 out of 15. Okay, there's no motor response. They're not responding to your voice, and there's no eye opening at all. Okay. So this is that is concerning. Obviously, you don't know the baseline. You don't know what they're like. That could be them. Okay. That could be what they're like. I had one a couple of weeks ago who was actually having non-epileptiform attacks. And I went and she was having an episode. And at first you look at that and you'd be really quite concerned about that. But then I read the notes and there was a clear note from neurology and neuropsych who'd said that that's the baseline for the patient and there's nothing to worry about. Don't give any benzos or anything. They should just self-terminate. And it did self-terminate and she came around a couple of hours later. As it wasn't an epileptiform attack, it's less concerning. It was very much a, you shouldn't use the term pseudo-seizure. They're called non-epileptiform attacks these days. But yeah, but generally GCS of 3 is concerning. And with that, you check their pupils and you find the left pupil's normal, but the right pupil is sluggish in constricting to light. Okay. And that really worries you with hypertension because you're worried that they might have had an intracranial event. Okay. So then exposure, like I was saying earlier, if you've got a diagnosis or a couple of differentials in the back of your head, then try and target your examination. And I would probably just do a neuro exam. And when I first started, so at med school, you'll practice neuro exams on awake, alive, compliant patients. Okay. It's actually really difficult to do one on an unconscious patient, and there's not a lot you can do. The main things are checking tone, checking reflexes, but you can't check power, you can't check coordination, and you can't check for their sensation either because the patient's not compliant. They won't be able to give you answers. They won't be able to listen to your instructions. So tone is really important. And if we're worried about intracranial event, hypertonia, okay, particularly spasticity. So check their upper and lower limbs. And also reflexes, check those. Have a look at them. Are there any fasciculations? But they don't tend to be early on. Those tend to be quite a chronic thing. And then look at the face as well. Is there any facial droop to one side? That's a good indicator as well. Okay, so it's quite a quick neuro exam, but it's very important to document. So what are our next steps? What do we think, guys? What are we going to do for this patient? What do they need? Very good, Amy. CT head. Yeah, I'd say they need 4 things to be done pretty quickly. One is a CT scan of their head. Yes. Because we need to know what's going on. Any others? What about that blood pressure? Are we happy with that? Yeah, ECG, very good. Just as part of your routine workout. I haven't put that on C, but yeah, quite right. Yes, very good. So the second one is controlling their blood pressure. And if it's that high, you should really put them on an infusion, okay? So you can give a stat dose of something. They won't be able to take anything orally. So it's going to have to be IV. So that's where you do need a cannula. And they'll need a cannula, although you probably wouldn't use contrast in the CT head. It'll be non-contrast to see if there are any acute changes. But yeah, you want to probably set up an IV infusion of labetalol to bring the blood pressure down. And sometimes that doesn't work and you need to use 2 agents. And the next would probably be something like a GTN infusion, okay? At this, you shouldn't be setting that up as an F1. Discuss that with the senior, okay? So this is pretty early on, probably after your D there and after your quick neuro exam, you need to be speaking to the med reg about this. And they can advise what to prescribe. Okay. So yeah, we've got CT head, we've got the labetalol. Next one, say we've done the CT head and we've got the result. And there is well, actually, I'll show you the diagnosis next. Okay. But that gives the answers away. But there you go. So this is the CT scan. All right. CTA, someone says CT angio. Yeah, very good suggestion. But they tend to do non-contrast first. And the reason is you can see acute changes like this, so bleeds, which comes out very, very much with, I think it's hyperdense, so similar color to bone, all right? A CTA you can do if there's no bleed and you think they might have infarcted. That is sometimes useful as well, particularly if you're referring to a neurosurgical center that will intervene. Okay. So the next thing to do for this person is contact a neurosurgical center. So in the southeast of England, the center is King's College Hospital, KCH. And send them the images. Now, does anyone, so we've got a bleed there. What else is concerning about that CT scan? I'm not expecting you to be able to interpret CT scans, guys, but it's just good for your learning. Yeah, fantastic. Okay. Barra just said midline shift. So here we can see the central sulcus going down and then it's attaches there as well. Okay. It's not in the midline. It's way shifted over here. The midline would be running up through there. Hopefully you can see my mouse. And not only that, this dark stuff around the white bleed is all edema. Okay. So edema really compressing large compartments of the brain. All right. So a bleed like this is really, really, really worrying. Okay. And if you have say this was a 20-year-old on a motorbike, okay, you'd probably go and evacuate them straight away. If this was a frail 80-year-old patient, the chances that you have to, and you should always refer to the neurosurgical center. That's part of the process. But the chances are they're not going to do anything. They're not going to intervene. They'll say, control their blood pressure and see how they go over the next 40 hours because the outcomes will be very unfortunate. Now, small bleeds patients can recover from. They most often don't get back to their baseline, but with good neurophysio and neuro rehab, they can get back to a fairly good quality of life. Large bleeds like this are very concerning, and the chances are they're quite often fatal, and that's why I've written there update family. Okay, and it's good to keep them updated early on because particularly if they've come into I know this scenario was on the ward, but particularly if they've come into A&E, having had a big bleed at home, the relatives will often be there because they're very concerned, and you just need to make sure that their expectations are appropriate from an early stage. Okay. So yeah, you do actually see these very, very commonly. Rarely you see them as an inpatient. It would be unusual to be called to the ward to be seen, to see one of these, but they often come through A&E, and they're very sad cases, because often there's not much that can be done, unfortunately. So last case is a young woman coming through to A&E. She's complaining of dizziness. So A, B, and C are all fine. Okay, there's nothing concerning at all, which is very reassuring. Okay, and that's why we do the A2E approach, because we can then think about the more important things. And again, D is reassuring as well. So BMs are fine. Good level of no problems with consciousness. Afebrile and pupils are fine. Okay. So then with the exposure, you're thinking, what do I need to do? Why is she dizzy? Okay. And you should tend to do like a systematic examination. So cardiovascular, respiratory, neurological examination, trying to find a cause. But the more important thing here, and that's why I put this case in, is thinking about the history. Okay. So you've got a woman who's dizzy, but they're stable. Okay. So you need to find out what is wrong with them. Yes, as part of your ATE, get an ECG, do all that. Okay. In the questioning, you need to think about, well, I'll go on to show you this. You might not have seen this before, but hopefully it's quite useful. Okay. So with pain for history taking, we still use Socrates. Okay. It gets rattled into your med school, but I quite often still use it. I don't necessarily write it out like that, but I always go through it in the back of my head to make sure I'm not missing anything. But for symptoms that aren't pain, Odipara is what I tend to use, and that's written there. And the reason is it's just slightly different things. And a funny story of my last year at med school, not my last, maybe second last year, we were taken to see, and I was taking history on a patient, and they said they had an itch. And I thought Socrates, fantastic. And then I asked them about the severity of itch, and I asked them to grade their itch from 1 to 10, which, as it came out of my mouth, sounded like an absolutely ridiculous thing to ask someone, how bad your itch is from a scale of 1 to 10. And that's why it's just a little bit different, and more appropriate for other symptoms. Okay. But there's similarities. So onset, when did it start? Was it sudden? Okay. Duration, has it been going on ages? Has it been going on a little while, or has it literally come on in the last few minutes to hours? Okay. Intensity, is it really severe? So that's like severity, but just a bit more general. Progression, have the symptoms got worse? Have they got better? Associated symptoms, which is a very important one, thinking about sinister causes for dizziness, so any chest pain, palpitations, shortness of breath, any loss of consciousness, any seizures. Okay. Relieving factors, anything make it better? Thinking about medications, is it positional? Are certain positions better? And then aggravating factors, are certain positions worse? Is it worse at a certain time of day? All of that, okay, is important to ask. And so just to finish, this woman, so all she's got is dizziness, and you come in, she says onset, it's been going on for a couple of weeks ago, it started. Okay. And it came on slowly, but actually it came on, and it continues to come on when I sit up in the morning, or when I'm lying down and I get up. That's when it's particularly bad. Okay. And that's when it's most intense, and then it'll go away, and it'll be fine. It doesn't progress. It's just it's most intense when I sit up. No other associated symptoms otherwise, other than she feels a bit nauseous, but doesn't get a headache, doesn't get an earache, and none of the sinister symptoms that we spoke about. Relieving factors are just staying still, helps, and aggravating factors, as I said, are making it when she sits upright. Any ideas what's going on? Any differentials, guys? Yeah, fantastic. Got it straight away. BPPV. Okay. Anyone know, for some bonus points, anyone know the test to diagnose BPPV? Very good. Yeah, Dix-Hallpike maneuver. Fantastic. So I don't actually know how to do it. I'd have to read it up, but you essentially get their head, lie them at 45 degrees, and you change the angles of the head. And the reason is because they've got little stones in their semicircular canals, so they're called otoliths. If they're in the wrong place, it can disconfigure your vestibular system and can make you really, it can give you real dizziness and vertigo when you change position. Okay. And then there's 2 maneuvers that you can use to fix it, to sort of rearrange the otoliths so that they're back in the correct position. Anyone know those? Epley is one. Brand-Daroff I haven't heard of, actually, but could well be true. And then the other one's Semont, I think, is the maneuver, but the Epley is the one that tends to be used. Okay. So that's BPPV. But also, don't rule out labyrinthitis or an inner ear infection, middle ear infection. Ask about ear symptoms, otalgia, tinnitus, all of that. Okay. So that's just a little bit about auricular stuff. And that is that, guys. So the QR code is there, but let me just come out and I'll copy the thingy and put it in the chat. So that should be it. And then please do give the feedback, guys. We really, really appreciate it, and hopefully are adapting